Welcome! If you're an MRCOG candidate gearing up for your exams, you already know that mastering the guidelines isn't just about memorizing random facts. It's about really understanding the clinical pathways and the hard evidence that backs them up. So let's dive right into this explainer, which is tailor-made for you. We're going to completely unpack the RCOG Green-top Guideline number 34, focusing on the management of ovarian cysts in postmenopausal women. This is a massively high-yield topic, and by the end of our time today, you're going to have a crystal-clear framework for assessing, triaging, and managing these patients with absolute confidence.
Before we jump into the actual clinical pathway, we really need to talk about the RCOG evidence grading system. Remember, the exam doesn't just care about what you do, but whether you know the strength of the evidence behind your actions. You're going to see grade A, B, C, and D recommendations sprinkled throughout this guideline. For instance, knowing which interventions are backed by top-tier meta-analyses versus the ones that are just, good practice points, well, that can literally be the difference between passing and failing an OSCE station. So keep that hierarchy in the back of your mind as we go. To make this super easy to digest, we're going to follow the chronological patient journey right through these 5 sections: initial assessment and diagnosis, imaging and tumor markers, calculating risk of malignancy, conservative management criteria, and surgical management and referral.
Okay, Section 1, Initial Assessment and Diagnosis.
This right here is your immediate clinical workflow when a postmenopausal woman presents with a potential ovarian cyst. First up, take a really thorough history, homing in on any family history of ovarian, bowel, or breast cancer. Next, you do your physical exam. You absolutely must check her BMI and specifically palpate for any ascites or nodularity. Then, order your initial investigations. Get that CA-125 blood test and do a transvaginal ultrasound. Oh, and here's a critical nuance for the exam. The guidelines are very clear that only cystic lesions 1 centimeter or larger are considered clinically significant for this pathway. If it's smaller than a centimeter, it doesn't even require follow-up.
Moving right along to Section 2, Imaging and Tumor Markers.
Listen up, because this is a classic exam trap. You really need to know exactly which diagnostic tools the guidelines support and which ones to avoid. It's so tempting in an exam scenario to go big and order advanced imaging right out of the gate, but you must strictly avoid ordering routine CTs, MRIs, PET scans, or HE4 markers at the initial assessment stage. The RCOG explicitly says no to routine CT and MRI as primary tools because, frankly, they have low specificity and expose the patient to unnecessary radiation. Stick to the gold standard first-line tools. CA-125 as your one and only initial serum tumor marker and the transvaginal ultrasound.
Next up, Section 3, Calculating Risk of Malignancy, or RMI.
This is the absolute core concept for triaging your patients. To do it right, you have to calculate the RMI using this specific formula: U times M times CA-125. Let's break it down. The U is your ultrasound score. You give 1 point for each of these features: multilocular cysts, solid areas, metastases, ascites, and bilateral lesions. Total of 0, U is 0. Total of 1, U is 1. But if it's 2 to 5, U jumps to 3. Now for the M, menopausal status. This is an easy one to remember. M is always scored as 3 for our postmenopausal patients. Finally, just multiply that by the absolute value of her CA-125 serum level.
200. Seriously, burn this number into your memory. A threshold of 200 is the grade B recommendation for separating low-risk cysts from those that have a genuinely increased risk of malignancy. If your patient's RMI calculation hits 200 or higher, it triggers 2 immediate actions. You order a CT of the abdomen and pelvis to check disease extent, and you make a direct onward referral to a gynecological oncology multidisciplinary team.
Now, while RMI is the classic standard, the guideline also fully accepts the IOTA classification as an alternative. So you'll want to contrast the benign features, the B rules, like unilocular cysts, acoustic shadowing, and zero blood flow on color Doppler, against the malignant features, or M rules. These are things like ascites, having at least 4 papillary structures, or irregular solid tumors. If a mass hits on any of the M rules, it needs an oncology referral.
All right, on to Section 4, Conservative Management Criteria.
Once we've assessed the risk, we're at a huge fork in the road. And we really need to debunk a common myth here. Do all postmenopausal cysts mean a mandatory trip to the operating theater? Absolutely not.
In fact, if your patient meets a highly specific set of criteria, they literally have a less than 1% risk of malignancy. To qualify, the cyst must be completely asymptomatic, simple, unilocular, unilateral, under 5 centimeters in diameter, and the patient has to have a normal CA-125.
If every single one of those boxes is checked, you can safely manage the cyst conservatively. You just bring them back for our repeat CA-125 and ultrasound in 4 to 6 months. And hey, if it stays the same or even shrinks after a year, you can discharge them from follow-up entirely. It's a fantastic way to save patients from unnecessary surgical morbidity.
Which brings us to our final part, Section 5, Surgical Management and Referral.
So, what about the patients who don't fit into that neat little low-risk box? The RMI score dictates not just the surgical approach, but also the location and the specific specialist required. If the RMI is under 200 but surgery is still indicated, a general gynecologist can go ahead and do a laparoscopy. The standard procedure is a bilateral salpingo oophorectomy, but crucially, the specimen has to be removed without any spillage inside a retrieval bag, ideally through the umbilical port. On the flip side, if the RMI is 200 or above, that mandates a full laparotomy and staging procedure, performed by a trained gynecological oncologist at a specialized cancer center.
Oh, and I want to highlight another massive exam takeaway regarding cyst aspiration. Note the strict Grade B recommendation. Aspiration has absolutely no role in standard management. Why? Because cytological examination of cyst fluid has incredibly terrible sensitivity for telling benign and malignant tumors apart. We're talking around 25%. Plus, you risk spilling malignant cells. So, aspiration is reserved exclusively for palliative symptom control in women with advanced malignancy who are simply too unfit for surgery.
So, we've walked through the whole pathway, from the initial clinical assessment and the strict rules on imaging, right through the vital RMI calculation and the exact criteria for conservative versus surgical management. But as you study this for your MRCOG exams, here's a thought to chew on. How might emerging prediction models change this well-established clinical pathway in the future? Do you think advanced mathematical models like the IOTA LR2 could eventually phase out the RMI formula entirely? It's definitely a fascinating area of research. Thank you so much for joining me for this explainer. Keep these structured takeaways front and center during your revision, and best of luck on your exams. You've got this.